Well, good afternoon, everyone. I just started talking and then I realized I had my mute button on, so I hope I'm not repeating myself. My name is Mark Skidmore. I'm hosting this webinar series called Combating Opioids, and it's sponsored by the North Central Regional Center for Rural Development and Purdue University under a grant from the Substance Abuse and Mental Health Services Administration. While I'm introducing the speaker and getting us going, I'd really want to encourage participants to complete the little polls here, including which state you're from. I also want to thank everybody for joining us. I'm guessing many of us are on Zoom meetings and working from home quite a bit, and so we're really glad that you're here joining us on the, for this event and for the issue of addressing opioids. And so with that, I'm going to go ahead and introduce our speaker, Professor David Young. He's a community resource specialist with extension and a research professor at Montana State University. I'll let him tell you a little bit more about his background and experiences. And the title of the webinar today is the Opioid Addiction Incarceration Pipeline, a national health crisis compounded in rural areas. I also wanted to bring your attention to the last webinar coming up in the series, and that is with Richard Spoth, Greg Polier, and Cassandra Knudsen on September 24th at 2 p.m. Eastern Time. And that'll bring the webinar series to a close. The title of that webinar is Capacity Building for Improving Behavioral Health in Rural America, Prospering in a COVID Context. So we'll hope that you have that on your radar screen and on your calendars as well. And I will also note that there is an area where you can type in questions in the chat box, which we can point David to, and he can answer them along the way or at the end. So please feel free as questions come up to type those in. And so with that, I would go ahead and ask Crystal to remove the questions and make room for the chat box. And David, it is my pleasure to have you on. Thank you again for sharing in this webinar.
Thank you, Mark. And I'm just going to do a voice control here. Can everybody hear me? I have my speaker right at about 50%. Does that sound good, or do I need to increase that?
You sound pretty good, just right.
Okay, great. Well, I didn't really want any introduction, but I want to just say welcome from Montana. And I see we've got quite a group of states represented. And I've been at MSU, Montana State University, for a long time. I won't tell you how many years, but have been blessed to work in areas that I am passionate about, and moving in different systems. Came as a department head and then moved into research for the university. As somebody once said, that if you enjoy what you do, you'll never work a day in your life. And that has been my history. So just a couple preliminary comments at the outset. My primary goal in this webinar is for you to learn something new that you didn't know before, maybe a nugget or a piece of trivia, something that is new to you. And you'll find embedded in several of my slides are URLs and links for more information for those who are curious and following up. And thank you very much for agreeing to select your area of interest, because as I went through this, preparing for this webinar, it was interesting that any of those 6 areas could be a webinar in itself. So I'm going to try to touch on each one of those a little bit. Some it'll be more than others because of our focus. And our travel agenda today is somewhat complex, so I encourage you to fasten your seatbelt and we'll take off on this trip. And I want to start off, see if I can get as a technically challenged person. I want to use a disclaimer first. I'm not going to read through that, but I like to have that in case anything results from information that I do present. And since I'm not into a lot of the pharmacokinetics and drugs and everything, I always like to try to just do an overview of opioids at a glance. What's involved here? Well, primarily, as you know, prescription pain relievers, and extends even into the street drugs and the illegal opioids such as heroin. I always have been, for a number of years, dedicating my presentations to this girl, 18-year-old Victoria. And I want to just give you a little bit of history because she represents one of the major glitches in the trauma or the substance abuse and trauma to prison pipeline or incarceration. She was arrested for the first time in her life in March in 2015. She told the intake staff at booking that she used 10 bags of heroin a day. You can read the rest of that, but she eventually was taken to a hospital and died, and her parents sued the jail in Pennsylvania and won $4.75 million. So not the best way to compensate, but it was an eye-opener for other county jails that they have to handle those with a severe substance abuse habit differently when they come into the jail setting. So this will really date me, but I grew up with this type of entertainment, connecting the dots, and I think that stayed with me through most of my life. And so that's what we're going to try to do here. The major dots we're going to connect are do a little overview of, maybe more than a little, of ACEs. We'll look at the criminal justice system, some of the health disparities of those who we are locking up in jails and prisons. And then I want to cover 3 pilot projects that I've been working on here at Montana State University with our county jail, and more recently nationally with a group in Chicago and a group in Augusta, in Georgia, at the university there. And just a note on collateral damage that the COVID-19 has caused for us who are working with the jail population. It has really changed the dynamics and magnified things, exacerbated a number of issues across the nation. And just a little bit on prevention of the trauma to incarceration pipeline, and hopefully end up with some good news. Want to cover some politically correct terms and definitions, if you haven't heard these, rather than referring to prisoners or inmates. The terminology, I think it was President Obama in 2016, encouraged individuals to use the term justice involved, which would mean anyone who has currently been involved with the criminal justice system. That's jail, prison, pre-release, community supervision, probation, parole, and even located in a treatment center. And the term incarcerated means that the individual is in a secure facility, such as a prison or jail, and an inmate is someone who's an individual in custody of a public institution held involuntarily through the operation of law enforcement. And then trying to remove the stigma of labels like ex-con or ex-offender or criminal or thugs. Individuals released from prison and jails into our communities are called returning citizens. So just a quick comment on there, as you probably know, if you've looked at the adverse childhood experiences history, there are three major types of trauma for children: abuse, neglect, and household dysfunction. And I'm just going to see if I can do this. If I can get my drawing arrow somewhere, but got to find it. Yeah, right there. I wanted to focus on that in incarcerated relative, and let you know that there are about 5 million children in the United States who have experienced a parent being incarcerated. That's about 7% of our population. And of those children, unfortunately, they are 5 times more likely to encounter the criminal justice system as they grow older. So let me see, do I have to put that arrow back up there? Got to get it down here. We'll go on to the next slide. Whoops. Let me go back. I think I missed one. These are the areas of ACE's increased health risk. And you'll notice that alcoholism and drug use, both up here, are high on this list. And also, just below that, you can see that anxiety, depression, and suicide are in that category too, which is another characteristic of our justice-involved population. So I'm not going to spend much time. You probably know about Nadine Burke Harris. Dr. Harris was the one that, this is her TED Talk, which I'm sure has had multiple, I forget the last time I checked, it was like 600,000 hits on it. And you can listen to that through this slide, and there's a link at the bottom. She has testified before Congress on at least 2 occasions. This is one, a more recent one. It's only 15 minutes long, but it's profound in an overview of the long-term health effects of childhood trauma. As you probably know, Dr. Harris has been appointed the Surgeon General in California for health, and she has instituted a preventive or at least identification program encouraging all pediatric state of California to conduct an ACEs test on children working with the parents. And they have launched ACEs Aware, which is a national website. So what do we know about ACEs? 4 ACEs on the score out of 10 or higher puts you in a high risk category. And here are some of the outcomes of scoring 4 or higher in your ACE score. You can read over those. I'm not going to read those to you, but just to point out a couple. Individuals with a 4 or higher ACE score are 10 times more likely to inject illicit drugs, and they're 20 times more likely to have been incarcerated at some point in their lives, and 32 times more likely to have behavioral problems. It's not news to most of us that high ACE scores end up with young people, teenagers, juveniles being locked up. And this is a good article that came out last year on adverse childhood experiences and the intersection with crime. So overall impacts of childhood trauma, and read through some of those. The increased frequency of substance use disorders and incarceration, increased frequency of mental illness and suicide, actually a life expectancy reduction of 20 years by scoring higher on an ACE test. I did find one article that I was able to connect a couple dots with rural population. The article was entitled, it's at the bottom there, Adverse Childhood Experiences Predict Opioid Relapse During Treatment Among Rural Adults. And they found that over half of their rural patients relapsed if they had a high ACE score. And also nearly half of them reported a 4 or more on an ACE score. So as we finish up looking at ACEs, I have some recommended reading. If you're not familiar with ACEs, Dr. Nadine Burke-Harris, her book, The Deepest Well, Healing the Long-Term Effects of Childhood Adversity, is an excellent book. The one in the middle, I think, is actually probably the best. The Body Keeps the Score. And then Be Childwise, a workbook that actually originated out of our children's home here in Montana, is another excellent book. Some quotes about ACEs. Dr. Robert Block, former president of the American Academy of Pediatrics, said that ACEs are the single greatest unaddressed public health threat facing our nation today. And the author of that book in the middle that we just saw, The Body Keeps the Score, he said trauma is now our most urgent public health issue, and we have the knowledge necessary to respond effectively. I'm got to redo lost my arrow here. There we go. So we're going to move to the criminal justice system. Just an overview, if you weren't aware, that we have, as you probably, maybe you didn't know, that the United States incarcerates the largest percentage of its population than any other country of the world. I think the statistics are that the United States occupies about 5% of the world area, but we incarcerate 20% of the population that's locked up. We have 2.3 million people in secure confinement. And one of the interesting things, I think, is that I ask people, what does Extension have in common with jails? Well, we have a presence in almost every county in the United States. As you see that, I highlighted that in red, that there are 3,163 county jails or local jails, and it's about the same number of counties and townships where we have extension agents and extension offices. There are 4.1 million in community corrections, and that's probation and parole and pre-release centers, different types of treatment areas, and halfway houses. So basically, we have 7 million Americans that we keep in under the criminal justice system. We also have nearly 12 million that are cycling through our jails each year, those 3,000 jails. And we have 600,000 individuals are released from prisons each year. So that's about 50,000 a month are entering our communities. So one of the facts about jails is that over 2 million people have serious mental illness, and we're locking them up. Unfortunately, jails have become by default our mental health centers. In prisons actually become geriatric centers because we have a aging population that needs a lot of health care. So one of the statistics I came across that was, I thought, surprising and might be your nugget of the day or trivia. In 1980, we were incarcerating about 26,378 women, various federal, state, and jails. And within a period of a couple decades, or nearly a couple decades or more, In 2017, that had increased almost tenfold. We currently, at the last statistics I could find, were incarcerating about 250,000 women in our jails and prisons. In 2015, this was the cover of the Corrections Today magazine, talking about how it was called ACEs Too High, the article, because the women who are incarcerated have scores of 9 and 10, and as many as 95% of the women we're locking up have very high ACE scores. The other thing that's a concern in our correctional system is health disparities, as you would expect. Our population that we lock up has chronic health conditions, and I'll let you read over some of these different parameters. Comparing the justice-involved population with the general population, as you can see, much higher percentage have chronic health conditions, substance use disorders, and one of the biggest ones is a history of past trauma. 70 to 90% of a history of strong past trauma. And educational attainment too is another interesting aspect, that very low level of educational attainment of people that we are locking up. So individuals leaving prisons, at least I was able to connect those two dots, the opioid overdose, they're 40 times more likely to die from an opioid overdose compared to the general population. And you can read through the rest of those. 12.7 times more likely to die within 2 weeks after release, usually due to an overdose or suicide. And the last item there, 12 times more likely to suffer from a substance use disorder and or a serious mental health condition. Actually, I read recently that 4 out of 5 individuals released from incarceration are suffering from an SUD or serious mental health condition or comorbidity in that issue. And as a community health specialist and a member of the Creating Healthy Communities of Extension, I keep telling people we cannot have healthy communities until we address the re-entering citizens that are coming from incarceration because of their health issues. Interestingly, there are some good criminal justice watchdogs across the United States. If you want any of those, a number of these are tracking almost on a weekly or monthly basis. The Community-Oriented Correctional Health Services has a newsletter every month. The Marshall Project has a daily update on what's happening in prisons and jails across the country. And found an interesting article or publication from the Vera Institute of Justice on rural jails as a research project, and that is available at the bottom of that slide if you click on that link. So now this is my test question. I know it's not Friday, it's Thursday, but I have a test question, and maybe they could type it in somewhere. What is the #1 predictor of our health outcomes? Is it age, race, income, education, employment, or level of health literacy? Does anybody want to give a guess to that? Got some coming up. Race. Karen. It is health literacy, believe it or not. That's a #1. What we know about our health and wellness and health condition is our #1 predictor of our health outcome. And seeing that, and also a advertisement or a solicitation from the National Library of Medicine and also from the USDA, working with health literacy. I started working in the area of health literacy, and these are just 3 publications of the National Academy of Science, Engineering, and Medicine. And notice the titles, hopefully you can read those, on community-based health literacy intervention, building the case for health literacy, and the intersection of behavioral health, mental health, and health literacy. I think all of those have come out within the last few years. So we developed here in our county a program to improve health literacy in our jail population. And this is a publication, and if you're interested, I can send it to you. That was our first pilot study entitled Improving Health Literacy with Inmates. And we developed 12 modules that we could take in and put on the desktop computers in the jail. As you probably know, most jails and prisons do not allow internet access. So we had to package what I called an internet in the box system with the help of our IT people in Extension. They did an awesome job of building an internet in a box, which would allow people to do searches through a system. Eventually it came to a dead end. But these were the 12 topic areas that we selected. Then our second pilot study was promoting health insurance and enrollment literacy with jail inmates, because as you probably know, a large percentage of people that we arrest and lock up have no health insurance. And even if they've had Medicaid, that is either terminated or suspended, depending on the state they're arrested in. And that is unfortunate, because then their health care, when they get out, they have to reapply for their Medicaid, and that takes several weeks or months. And it's during that time that they have a high incidence of ending up in emergency rooms. So it's a high cost. And our third and current pilot study is promoting health literacy and improved self-care management using a secure tablet technology. After those first 2 studies, I was approached by a group in Chicago called Edovo that handles or distributes the tablet technology to prisons and jails. And also Augusta University had an interest in joining with us on a grant to the National Library of Medicine, which was awarded in 2017. And we're just finishing that. It's a 3-year grant. So we'll have some interesting data to look at. That's just a review of who's involved in our study. And this is a picture of the tablet, and there's more information on that link that you see on that slide, if anybody's interested. And a lot of people ask, why work upstream with trauma? And that's a no-brainer as far as I'm concerned. Dr. Nadine Burke-Harris has identified these 6 pillars of ACE prevention with children, and trying to get these instituted or implemented throughout California, working through the pediatric clinics, healthy nutrition, physical exercise, mindfulness, mental health, supportive, nurturing adult relationships, and good sleep hygiene. Just a note on the mental health issue, my wife and I raised 2 grandchildren, came to us at ages 2 and 3. We had them for 16 years, and they were poster children of ACEs because of the brain changes that they had experienced in their younger lives from 0 to 3 years of age. And one of the best things we saw was our school system here implemented a dialectical behavioral treatment, DBT program. They were identifying kids that had severe trauma issues, and they were diverting them to this class in the high school. And it, as far as I'm concerned, was the main reason that those two girls are still alive today, and they did graduate from high school. So that's one of my passions, is a prevention and a jail diversion and a suicide diversion program. The other area of prevention that I think is the Justice Clearinghouse is working on, and that's trying to train justice professionals, correctional officers about trauma, because arresting and incarcerating an individual who has severe trauma background is just re-traumatizing them. So that's a real plus. So looking ahead, what's in the future besides a reality check, which is what COVID has done for us. And just a note on, I apologize for not giving more information on COVID, but the case rate in jails and prisons, it was just published a month ago in the Journal of American Medical Association, that it's 5.5 times higher than the general population for those who are incarcerated. Not surprising, because you can't really control social distancing and other things with eating and showers and other activities in the prison system. So moving along, my goal is to be done within 30 minutes so we can have time for questions and answers. Good news is that there are many states, and I'm pleased to say our state of Montana is working on prevention and treatment of ACEs and jail diversion programs. If you're aware of the launch of Healthy People 2030, they've identified incarceration as a significant social determinant of health. In fact, incarceration is bad for your health, if you want to know the truth. So that's a plus. And if you go on the Healthy People 2030 site and just type in your area of interest, you'll find they are addressing ACEs and ACE prevention. The Substance Abuse and Mental Health Services Administration, the Gain Center, is offering trauma-informed training for correctional officers, and it involves community members. Our two communities in Montana have 13 individuals are certified to offer that training in our state. And in August, 125 national organizations, including the National Association of Counties, signed a letter to Congress encouraging them to include the Medicaid Reentry Act in the next COVID funding, which would be a major game changer for the health and well-being of our justice-involved population. So, time's up. And time for questions.
Thanks a lot, David. So if you do have a question or a comment or something to share, you can type it right into the chat below, and we'll try to monitor that. To get us started, David, I just was wondering, you started with the case of this very unfortunate situation with this young lady who had severe disorder, and she died in prison. How common is that? And are there, what proportion of jails and prison have some sort of maintenance program so that you don't go into severe withdrawals if you are for some reason incarcerated?
That's a great question, Mark. And unfortunately, it's happened more than we would like to see. I think soon after this case, there was a case in Alaska. He died, but a number of the county jails are now doing an assessment at the time of booking or intake and determining if the person is having a serious substance addiction issue. and they are instituting a medication treatment program. It's called MAT, Medication Assisted Treatment. So that is improving, but it's been a high cost area as far as the deaths of individuals who were just thrown in a cell and not addressed that they needed to have some type of taper dose, some type of a dose to bring them down off of that high level. She was on a very, very high level, as you saw, of heroin.
Thank you.
I should add too that hopefully it was on my cover slide, my email address. If anybody has questions or would like additional information or articles, just shoot me an email. Or if there's an area, I know there are many. This was a Swiss cheese presentation with lots of holes in it. So if there are areas that you were interested in that I missed, I'd be happy to give you some more information.
David, do you see the question coming in from Tessa?
Yeah, I see. What steps can community members take to better support those reentering and striving for substance use recovery? Oh, great question. Yeah, there are a number of touch points in the communities that I would suggest. Number one, of course, is get to know the administrator of your county jail, and or if you're in a county where there is a prison, get to know that administrator. In most of our rural communities, the sheriff is the control arm of the jail, although there may be an administrator under them. And then the other thing was get in touch with your community health center. If you have a FQHC or like in our state of Montana, we have, I think, 17 community health centers, and they've been awesome. And then also a mental health center, because I really believe that it's a very high percentage of comorbidity with that substance use and mental health issues, serious mental health issues. And the substance abuse is really a self-medication for most of them. So, okay, the next question, are there any resources for doing an audit of a community to make it more trauma informed? Yes, definitely. There are, and there are a number of programs to make pretty much all of your key community organizations more trauma informed, from the schools to the hospital to the clinics to the community health centers, all those key agencies that are really seeing children. I really think that our education system, where we are training teachers, I don't know how many times my wife and I have been out for dinner and we ask the waitress or waiter what they're doing with their life, and they say, "Oh, I'm in the College of Education," and we ask them about what they know about ACEs, and they've never heard of it. So I think we need to really move in that direction. Yeah, if you could send me ask that question to my email, and I will come up with some information about an audit for being more trauma informed. And then, Tessa, let's see, what misconceptions about this population do you most want to see change? Excuse me for laughing, but I couldn't finish. See change for widespread shifts on this issue. Well, you talk about discrimination. My wife works in the jail too, and on our programs that we have. And I don't know how many of our friends look askance at us and wonder, what the heck are you doing with that worthless population? So it's a stigma But these are all human beings who made a mistake. There were just recently in our jail two guys that they didn't know each other, but they were separate cases. One drove home, hit a girl on a bicycle and killed her. So he's in our state prison under 20 years. And another one was a hit and run related to alcohol. So, um, yeah, I think that's a great misconception that these people are throwaways, they're worthless. Um, so hopefully we can change that idea that they're not a bunch of thugs. And so Lauren says, we know racism is a public health issue and implicated in ACEs, but often racism in rural areas is ignored or minimized. And you talk about specific role of racism in drug-related incarceration for rural areas and what resources are available for community level prevention. I would say that you're right that it's ignored or minimized, but it's definitely an issue. Uh, Racism is a very, very high issue. And in our state of Montana, we have 7 reservations, American Indian reservations. We have 12 tribes. Uh, those Indians represent 7% of our population, but they represent 19% of our men in our state prison, and they represent over 20% of the women that are locked up in our women's prison. So, yeah, the prevention in our state or in any area where there's racism needs to again start at the ground level, and that goes for our rural areas. Um, that we really need to address that. It's definitely a problem for rural areas. I don't know if I answered that question, Lauren, but if you want to send me an email, maybe we can converse more on that.
David, when you think about how high our incarceration rate is in the US and couple that with substance use disorder and ACEs and all of the interrelationships, can you think of another country that handles this issue in a healthier way? Because we're certainly not the only country that struggles with these challenges, and yet our incarceration rate and the numbers of people with these kinds of challenges end up there instead of someplace else.
Good question. And there are other countries definitely that are doing a lot better than us in handling the situation. I haven't had the time to uh, investigate some of those, but I have seen some publications about Norway um, and other countries who are not as harsh as we are in handling our um, population that gets entangled with the criminal justice system. And the sad thing is that once you come through that gate into the criminal justice system, you are marked, uh, unfortunately, and it's like dragging a dead horse around when it comes to housing, getting a job, anything. Thankfully, in our community, the last time it's not for public record, but I counted up over 20 businesses that routinely are hiring people that come out of the jail. And part of that is because they have compassion and a heart for individuals, but also know that these individuals coming out are really going to be good workers, because if they've made that turn and changed their life, they are going to uh, be good quality workers, somebody they can trust.
Okay, I think we're getting close to the end. I don't see any other questions popping up with the participants. For the participants, I see many of you have filled out the questionnaires. That really helps us sort of learn more about where you are and assessment of the webinar and the usefulness of the webinar. So we really appreciate you filling those out. I think we have maybe one more question coming in, and maybe at that point we'll stop as soon as we're done here. And Alisa has a comment or question.
Yeah, that question I was just reading again. Any program models for folks coming out of incarceration, given that the first 2 weeks seem to be rather critical? Yes, there are a number of reentry programs, and if you'd send me an email, I can provide you with some information on those reentry programs. The real how do I want to say, progressive jails and prisons actually start working on your reentry as soon as you get booked in. They do a profile of what your issues are, where you came from, if you have a substance abuse disorder or opioid use disorder, or if you have other issues that need to be addressed on your reentry. So there are a number of excellent reentry programs. Prison Fellowship is one that has for prisoners and jails, but I could send you some of those program models that community members could be encouraged to work on, develop their reentry program. We have in our county, we've been blessed to have actually a reentry program officer at the jail. It's a full-time position that we got the county to fund. As you probably know, the county gets stuck with the cost on a lot of the health care because the National Association of Counties has been a leading force in trying to in criminal justice reform, because they are responsible for the county jail system, and it's become more costly. I think we're spending $12.3 billion on health care for prisoners across the United States. That's billion, 12.3 billion. So there's a lot of money involved in health care. Okay, let me see if I can.
While we're
I can send you more information. How do we get certification of participation? That must be Mark's question, right?
Yeah, I think I'll try to answer that. I know that certain aspects of the grant program there is certificates of participation. So if you would like a certificate of participation for the webinar, please send a note to Crystal Witt, and I've included the email here, and we'll check on it. We haven't had that question come up with webinars, whether or not there was certificates of participation for webinars. I don't know that we have that, but we will check and get back with you if you send us an email. Okay, with that, I think we will go ahead and call it a conclusion for this afternoon. I want to thank you, David, for sharing this critical information, and thank the participants for joining us. And I hope everyone has a great afternoon. Thanks again.
Thank you, Mark. Have a great day.
You too.